Hello, this is Dr. Vaasanthi, consultant cardiologist at Onus Hospitals, Champapet. So today we will be discussing a topic about CT calcium scoring and CT coronary angiography. So what are these and what the difference between the both? So first coming to the benefit of both, actually when we do the CT calcium scoring and CT coronary angiography, we can detect the CAD coronary artery disease at a very early stages. It's a non-invasive method and it can be done with the cardiac CT technology. So CAD, as we all know, it's a leading cause of the death, and early detection is going to help to prevent a heart attacks, which can further help in managing, like before the LV function decreases, we can manage these blocks and further damage to the heart muscle. So CT imaging provides a non-invasive methods, and as we all know that the angiogram is an invasive method. So instead of the like patients when we are not sure whether the patient is going to get the lesion or out of the just to screen the patients, we are performing this angiogram test. It's better to go for the CT coronary angiogram, and in and furthermore, if the patient is having just the risk factors, and we need to risk stratify the patients much more for starting off any hypolipidemic drugs or anything, then we can do the basic calcium scoring test, and according to that we can decide whether the patient needs lifestyle modification or the patient needs any drugs to modify these risks, or whether the patient needs any invasive methods. So coming to the CT calcium scoring, it's a non-contrast CT scan. So it is going to measure the amount of the calcium deposited in your plaques in the arteries. So that is directly proportional to the blockage. We do it on the basis of the Augustin scoring. It just takes around the 5 to 10 minutes, and we are going to stratify the patients again based upon this Augustin scoring. If it is a 0, there is a no detectable disease. 1 to 99, we call it as mild plaque. 100 to 399, it's a moderate risk, and 400 platelets is a high risk. So usually when the CT calcium score is 400 and above, we advise the patient to undergo the conventional angiogram. When the score is above 100 and less than 400, then we advise a patient to undergo the CT angiogram, CT coronary angiogram, to rule out any further the amount of the blockage and everything. And one more thing we can tell that when the patient is having a, suppose a patient is a hypertensive and diabetic, and he's a, if the patient is having little bit elevated cholesterol levels, then if the patient is, we need to put the patient upon the hypolipidemic drugs. Then we can dissatisfy according to this. If the patient is having the score above 10, then patient needs the hypolipidemic drugs. So what are the benefits is with the CT calcium score is there is no contrast injection. It's a quick and painless. It's a low radiation exposure, early risk stratification, and it's a preventive planning. So coming to the CT coronary angiogram, CT coronary angiogram slight more radiation compared to your calcium scoring. So usually on when we do just do the CT calcium scoring and the risk is above the 100, we suggest the patient to undergo the CT coronary angiogram, or the patient is having any risk factors and having not having much symptoms, and we are not sure whether the patient is having any lesion. Then for the screening purpose, we can go for the CT coronary angiogram. It's a contrast enhanced CT scan. It provides the 3D images of the coronary arteries. It is going to detect the blockages in the coronary arteries. It is a non-invasive and alternative method to the conventional angiogram. So in the CT coronary angiogram, we are going to give the IV contrast injection and perform this one under the high resolution CT imaging, and usually it will take around the 10 to 50 minutes. So when we are giving this dye injection, we will see how the vessels are going to fill in the CT angiogram. It's whether the dye is flowing freely, then there is no blockage. When there is an obstruction to the flow of the dye, there we suspect the blockages. And apart from the CAD, we can detect the other things from the CT coronary angiogram, like any coronary anomalies. In the pediatric age group, when they have the chest pain on the echo, we suspect that there are some coronary anomalies. Then also we can advise for the CT coronary angiogram. And even the post-stenting patients, when we think like after the stenting, and when we suspect like whether how is the stent, whether there is any restenosis in the stent. In such cases also, instead of the conventional angiogram, we can go for the CT coronary angiogram if the stents are not smaller. If the stents are much smaller stents, then there are the chances of the artifacts more in the CT coronary angiogram. So these are the scoring pattern which we give on the CT coronary angiogram. We call it as a CAD RATS. If the CAD RATS is 0, there is a no detectable plaque. And if the percentage is 1 to 25, it's called as a mild. It's a minimal. 25 to 49, it's a mild. Above 50, but less than 70, it is called as a moderate. And more than 70, it's a severe stenosis. So usually when this CAD RATS gives a more than 70% in the report, then we advise then we take up the patient for the coronary angiogram. If the score is about the 50 to 69, we decide upon the patient symptoms whether to go for the coronary conventional angiogram or whether to perform the functional imaging. Functional imaging, like we can do the dobutamine stress MRI or the PET-CT with the stress to detect the any decreased blood flow during the stress. And coming to the minimal, we just give for the life support, and mild also we prefer for the life support. But there are the certain risk features on the CT angiogram where we have to take up the patient for the conventional angiogram, like when there is a LMCA disease, when the left main we are having the plaque, significant plaque, or whether there are the triple vessel disease when all the three blood vessels are showing up blockages. In such cases, irrespective of the CAD RAT score, we have to go for the coronary conventional angiography. So the advantages of this CT coronary angiography is it's a non-invasive method and no hospital administration is required for that. So highly accurate when it is done under the good 128 like slice CT, we'll get the very good images and it's highly accurate. And we get the results also very quickly, and negative predictive value is also very good. So we can use the CT calcium score and the CT coronary angiography as a screening tool instead of the conventional invasive method for the low risk and intermediate risk coronary risk patients. So like to whom we suggest this the calcium scoring on CT coronary angiograph is age should be more than 40. Usually less than 40, we don't prefer the CT calcium scoring because there are the no calcium plaques to detect the calcium score. And a patient with the risk factors like diabetes, family history, smokers, or there is a chest pain, but it's like atypical. In such cases, we prefer for the screening test, non-invasive coronary angiogram. So, and my further limitations of this one is we have the radiation exposure, but it's a very minimal. And one more thing to consider is a contrast. So during the CT coronary angiography, not the CT calcium score, we gave the dye injection. And this dye is going to, some patients are going to have the allergy due to the contrast, allergic related reactions, which can be to the mild to the severe. And the renal function test, we need to look for the kidney function test prior for any CT coronary angiogram because the dye is going to extract through the kidneys. So any altered RFT, usually we don't prefer the CT angiography because if any lesion, again converting to the conventional angiogram, the dye there, again the contrast used there is a double exposure. And when the patient is having the irregular heart rates like atrial fibrillation, in such cases, we can't use for the coronary angiogram. So nowadays, we can see that the rate of the patients who are getting it done for the CT coronary angiogram is increasing because the patients are preferring because it's a non-invasive method and they were getting getting done in a very limited time, like 5 to 10 minutes of time. And we are going to have some negative predictive value so that gives a relief to the patient. So all these are developing features of the CT coronary angiogram. So take-home messages is whatever we are suggesting for the CT calcium scoring or the CT coronary angiogram, it is going to detect your coronary artery disease at the very and it better risk correlates with your risk prediction so that we can stratify the patients according to the management based upon whether lifestyle or we have to go for the invasive. And however, it's a non-invasive, so it is patient friendly. For any information further, do contact us at Onus Hospitals, Champapet. Thank you.